It's our pleasure to welcome our next presenter, Dr. Sankalp Singh, Reproductive Medicine, Infertility and IVF Specialist at Yami Fertility Center, Indore. Dr. Sankalp Singh will be speaking on the topic Paternal Aging and Male Contribution to the Results of Assisted Reproduction. A warm welcome, Doctor. Over to you.
Thank you very much for the kind introduction. Respected chairpersons, seniors, colleagues, a very good morning to all of you. So at the outset, I would like to thank Dr. Jayakrishnan and the team for inviting me for the talk. It's always been a pleasure being at Advances. So the topic for me for today is paternal aging and male contribution to results of assisted reproduction. Now, as we see, the egg oocyte and the sperm, they have to combine to make the embryo, and then the paternal factors becomes very important over here. So the paternal factor which contribute to the early embryo development includes the epigenetic component of the sperm, which can lead to problems in the embryo as well, the epigenetic disorders. The seminal plasma component, which helps in implantation, the fertilization factors which helps in making of the embryo, and the genetic components like DNA integrity, RNA and other proteins. So the genetic component is the most important one, and it will be one of the main focuses of the talk. So the problem now what lies ahead is, over the past 4 decades, the mean paternal age has increased from 27 to 30.9, and percentage of fathers which are older than 40 has more than doubled. Paternal age more than 40 has been shown to have a higher rate of failure to achieve a spontaneous conception. So this particular data graph, if you see, it is from UK, so from 1990 to 2020, and we can see very clearly how the paternal age is rising in continuity. The definition of advanced paternal age, it lacks unfortunately a uniformly accepted definition, but ASRM and most of the studies suggest age more than 40 as advanced paternal age, though in the researchers they have even studied about more than 45 and more than 50, but most of them are more than 40. So the flow of the talk would be like this. First, I'll be discussing on non-genetic issues, that is a general effect on reproductive system and effect on semen parameters. Then I'll be discussing on the things which are dependent on the genetic component of the sperm, like effect of DFI, embryo quality, miscarriage rate, live birth rate, perinatal outcome, and congenital anomalies and long-term health, because these are mainly dependent on the genetic component. So let us start with general effects on reproduction. So there is a known histological alteration like testicular vascularization goes down, Sertoli cell and Leydig cell numbers go down. Then there are hormonal changes like testosterone reduction, and FSH and LH level, they increase. So these physiological changes lead to 1 to 2% annual decline in serum testosterone from 30 years of age. So this reduced testosterone can be either due to a reduced SHBG, a reduced Leydig cell number and function, or because of the decreased kisspeptin neurons and receptors, because that controls the GnRH pulse, which when goes down reduces the FSH and LH levels, leading to a reduced testosterone. So what that does, apart from the ART perspective, is it reduces the libido and causes erectile dysfunction. So prevalence of ED is 40% in men at 40 and 70% of men at 70 have an erectile dysfunction. The reason is mainly age-related alteration in the endocrine system, that is the stimulation, the hormone level. It's not mainly the age-related target organ damage, it's mainly related to the endocrine level. So once they are corrected, we can actually get rid of the erectile dysfunction. Coming to the second one, that is effect on the semen parameters. So a very, very elegant study of 94,000 men across from 90 studies, and age was associated with a decline in semen volume, total sperm count per ejaculate, total and progressive motility, normal morphology, and an increase in DNA fragmentation. The largest effect was seen for progressive motility and the DNA fragmentation, which becomes very important. Coming to the genetic issues, there are age-related alterations in various genetic parameters like the chromosomal abnormalities, telomere elongation, oxidative stress, DNA fragmentation, gene mutation, microRNA changes. So the main crux behind this is the spermatogonial stem cell, they constantly divide throughout our lifetime. So unlike egg, they just don't stop. They continue their divisions, as you can see from the graph below, that it just keeps dividing here. So there is a continuous replication. So if you see, when the comparison was done, so sperm chromosome has duplicated 150 times by the time a man is 20 years and 840 times by the time a man becomes 50 years old. What that does is it causes higher likelihood of replication errors in the germline. This leads to a 4% annual increase in de novo mutation risk to the offsprings. So what does sperm contribute? The main contribution is the genetic material. So if the genetic material transferred to the embryo is robust, then does the age actually matter? So what happens is, if there is a DNA damaged egg and if it combines with a DNA damaged sperm, if it combines with an egg and gives us a zygote, then the damaged DNA, basically it had failed the correction from the sperm part itself. So the sperm was not, the internal factors in the sperm, the anti-ROS has not been able to correct the DNA damage of the sperm. That's why that DNA damage has been transferred to the zygote. Now the DNA repair will kickstart from the maternal genome. So now egg will try to correct the DNA of the sperm. This can have three outcomes. Either it can undergo apoptosis if there is no correction. Sometimes there is a correction but not to a complete extent, so that leads to tolerance, which leads to then carcinogenesis and mutations. That's the reason that abnormal embryos and aneuploidies, chromosomal abnormalities and defects are commoner. Third is the normal DNA, when there is a complete repair which happens. Now, what matters the most for the DNA repair of the embryo is the age of the woman. So if the age of the woman is less, there is higher chance that the DNA repair will take place. While if the age of the woman is more, the DNA damage repair chances are less. Okay. So at no age is the DNA repair by oocyte absolute. So there is no age of the woman which can repair the oocyte 100 by 100% chance. The repair actually depends heavily on the extent of the DNA damage, and aging even of the lady, it reduces the DNA repair by reduction of the expression of mRNA and other key genes. Coming to the next, that is DFI. So as such, the sperm has lower chance of DNA damage because the mitochondria is in a separate compartment, that's in the neck. So the ROS have to travel all the way to the head to cause a DNA damage. While in the egg or other somatic cells, it's in the same cytoplasm. So the DNA damage is more commoner in a somatic cells. If you see the effect of age on DFI, so there is more than doubling of DFI between 20 to 60, and patient age more than 40 had higher DFI than those less than 40. A systematic review, 2022, 19 articles, they concluded that more than 40 years age is associated with a high DFI. What are the causes of the high DFI? It's age-related mechanisms, exposure to environmental toxins, increased incidence of diabetes, inherent sperm characteristics such as accumulation of ROS, prevalence of varicocele, which increases by approximately 10% per decade of life, and absence of antioxidant property and less DNA repair mechanisms. Coming to embryo quality, there are two parameters which we have to see in the embryo. One is the morphological quality of the embryo, and second is the genetic quality of the embryo, which can be seen only by the pre-implantation genetic testing. So if you see the morphological one, so fertilization rates are lesser in advanced stage, leading to lower embryo numbers. That is 0.3% lesser ICSI fertilization rate with each year increase in the male age. Blastocyst number and quality, it lowers down with advanced age. So this study of more than 4,000 patients with unselected maternal age, that is, they have not restricted their analysis to a young lady. So what they found was that the blastulation rate and the euploidy rate were significantly higher when the father's age was more than 40. Now, another group, they say that, okay, now let us control the age of the mother. So they just saw it in the donor group, that young donors, and then you study the effect of the advancing age. So the donor age was less than 33. So when they stratified as per the male age, there was same euploidy rate in all the three groups, less than 40, 40 to 49 and more than 50. But more than 50 still had a lower fertilization rate. When they analyzed it again by increasing the donor age, that is, they just checked when the donor age went up from 25 to 26 to 27, 28, there was significantly a higher increase in aneuploidy rate. So each year increase in the donor age increased the risk of aneuploidy by 4.1%. Coming to effect on the miscarriage rate and the live birth rate, so there is higher risk of pregnancy loss and lower risk of lower chances of live birth rate. A very good meta-analysis done in 2022, it showed that in a natural conception up till as the age increases, male age, so 40 to 45, 44 years, there is significant risk of high risk of spontaneous miscarriage, and similarly in more than 45 years, even with spontaneous conception, there is a high risk of a spontaneous miscarriage. So there is twice the miscarriage risk if the woman is more than 35 and a man is more than 40 versus a woman less than 35 and man more than 40, because again the correction by the oocyte is not possible. Then each additional year of paternal age increases 12% higher odds of not having a live birth rate. This study of 77,000 non-donor cycle, as per the SART data, showed that paternal age more than 46 or more than equal to 46 had a lower chance of pregnancy and live birth rate, and when this was again in women less than 35, it was not significant. One more study, 28 meta-analysis of 28 studies. It compared less than 40 and more than 40. So less than 40 had higher clinical pregnancy rate, live birth rate, and reduced miscarriage rate. Then this was the HFEA data. This is the biggest analysis done till date, published last year, of nearly 60,000 couples. So if the female age is less than 35, there was no effect of advanced paternal age. If the female age was 35 to 39, the advanced paternal age reduces the live birth chances, whereas if the age is more than 40, there is no effect again. Now the reason is that in young age the DNA repair takes place, whereas when the female is more than 40, there is no scope of a DNA repair because there is more damage in the egg also. That's the reason that the repair does not take place. But it has come up with a very, very interesting finding, that is, there is no effect of advanced paternal age if ICSI is done versus IVF. The exact reason is yet to be found out, whether you are selecting one sperm and there is, by luck, you are getting a chance that it has a normal DNA. But then this has become an indication that maybe in advanced stage you should not be doing IVF, it should be ICSI as the technique. So then they decided, okay, let us take the same donor, a young donor, and divide it into two parts. Use the sperm in 10 eggs, use a sperm of less than 45 and the other one more than 45 years. So this was done in this study, but still what they found was that there is 65% lesser chance in more than 45 year group. So even when they did a sibling study, even then the same donor is there, still there is a higher chance that if the age is more, then there is a higher chance of lesser chance of a pregnancy. Coming to perinatal outcome, so there are many ways through the DNA damage which it affects. In natural conception in men more than 35, there is 1.26 higher risk of miscarriage compared to less than 35, and in men more than 45 years, there is high risk of late stillbirth, low birth weight babies, preterm births, and very preterm births. Coming to congenital anomalies and long-term health, there is high risk of cleft lip, cleft palate, diaphragmatic hernia, achondroplasia, urogenital anomalies, and congenital heart disease. For the achondroplasia, the relative risk for these single gene disorders is 1.3 to 12 with paternal age of more than 40 years. Also, increased chances of childhood cancers, death in childhood, and psychiatric illness like schizophrenia, autism, and dyslexia in the child, with a relative risk of schizophrenia of nearly 3, which is extremely high when the father's age was more than 50, and of psychiatric illness of 1.5 to 5.7. So what does ASRM recommend them? So a very interesting recommendation from them, that clinicians should advise couple with advanced paternal age, that is more than equal to 40, that there is an increased risk of adverse health outcome of the child. So I think legally now it might be on the safer side for us as a clinician to take this in our consent form and advise this when the paternal age is more. The American College of Medical Genetics recommend that more than 40 years at conception, you should advise a genetic risk counseling. That is, let them undergo a complete genetic risk counseling and then only go ahead with the procedure. So how to reduce the negative impact of the age? So to counteract the issues with the dysfunction in the ART, erectile dysfunction in the ART cycle, what I practically do is freeze the semen for use if there is a collection for all patients, because if they are not able to collect on the day of the OPU, then you don't have any sperm to do the IVF. So I do it regularly for all patients, but if you are not doing it, then definitely for advanced paternal age it is advisable. Second is, there is an increased possibility of underlying coronary artery disease in these patients. So you have to be cautious when you are using the PDE4 inhibitors, because that can lead to a heart issue. Then what are the other ways how you can reduce the impact? You have to counsel for the timely pregnancy, that they should go for pregnancy earlier and don't delay it too much. Use of donor sperm is one option. Whosoever is ready, age is quite a lot and they are okay with it, they don't want to take a risk with the baby, use of donor sperm is an option. Social sperm freezing. Now we have talked a lot about social egg freezing earlier, but I think this is the time where we should counsel the patient. If somebody is into career and not planning the pregnancy for next 10 years and in their 20s or 30s, maybe this is a valid option. Freeze the sperm, 1 or 2 sample that can be frozen for years. So social sperm freezing might be the need of the hour. Then newer technologies. So the newer technologies means use of devices which can filter out the bad quality sperm. So here it is, the what we use is the microfluidics. So this was the study of retrospective study of 189 oocyte ICSI cycle with donor oocyte. So significantly higher chances of a pregnancy implantation rate and live birth rate when microfluidics was used, because that selectively takes out the sperm which have a abnormal DNA. So as you can see with the graph, it is pretty good, the pregnancy rate for the microfluidics group. So the conclusion is, success of ART is influenced mainly by maternal rather than the paternal factors. More than 40 years at conception is the most accepted definition of advanced paternal age. Fall in the routine semen parameters normally happens with age. DFI increases with advanced age, and a routine DFI check is advisable practically in men who are more than 40. Advanced paternal age negatively affects ART outcome, including live birth rate, though the impact is lesser in younger women because of the correction by the oocyte. Increased risk of adverse perinatal outcome, birth defect and long-term effect is seen in the offsprings of the people of men who are of advanced paternal age. Semen freezing prior to OPU and cautious use of PDE4 inhibitors is advisable. Double ejaculate on the day of the OPU may help reducing DFI. Again, one of the practical points that when you do IVF on the day of the OPU, tell them to collect 2 samples, because the second sample usually would be much fresher one and the DFI would be lesser. So we do it regularly for all the patients, but if you're not doing it, then at least this one would be the indicated case where we should try it. Technologies like microfluidics may help reduce the negative impact of APA, and it might now be unethical not to counsel APA men regarding the effects on the child. So as an obstetrician, first before a reproductive medicine specialist, now it's my responsibility to ensure that the baby's outcome is not compromised. Thank you for your patient hearing.
Thank you so much, doctor, for your valuable insights.